It's a pleasure to participate and contribute today. I remember doing it twice last year, and it really is I find it very satisfying, very enjoyable to be able to share my experience, my knowledge with others in this way. So today I've pitched my teaching, particularly at the postgraduate higher specialty training level, and with the assumption that most of you know about thyroid disease to some extent, and you know about the interaction of different hormones. So we're going to go straight into a very unusual and interesting informative case study. And there's quite a bit of information, and together with a colleague, I worked this up when I was working in Liverpool, and I still had it in my file. I've just updated it a little bit, and that will get the ball rolling, and then we'll look onto some other cases after the initial long case. So in the first slide, which I think you can see here, with a lady with a gross, very severe goiter, probably iodine deficiency. And iodine deficiency, I've discovered, is the most common cause of thyroid disease in Africa. It varies quite a bit. In some areas there's not that much. Other areas there's a very high prevalence. So we'll be considering the implications of iodine deficiency as we go along. And the other photograph is a very dramatic, brilliant picture, I think, of somebody with exophthalmos, protruding eyes, in a case of autoimmune hyperthyroidism. And as you may know, the protrusion of the eyeball is also an immunological process where there are antibodies to tissues at the back of the eye, which it cause swelling of those tissues, and the eye comes out in this way. So that's just an introduction to show you what I think are some amazing photographs. So if we go to the next slide, where we'll start on our case. And this is about a woman who first presented many years ago, at the age of 42. And at that stage, she had palpitations, and she was short of breath, and that had been going on for just about a month. And she was feeling a bit more tired than she usually was. So next, she came to the hospital clinic, outpatient clinic, and some more information was that she doesn't smoke, she drinks moderately, there's no family history of thyroid disease, and she doesn't take any medication by prescription. Next. So she's examined by the doctor, who finds that there are no physical signs of thyroid disease, that is, that she's euthyroid on examination. Her pulse is steady, it's not increased or decreased, it's pretty much ordinary. There's no shaking, no tremor, and the eyes and her neck are normal. There's no swelling on palpation around the area of where the thyroid gland is. So next slide shows the initial laboratory results. And at that time, and I think most laboratories will measure these hormones as part of the thyroid function test profile. Sometimes only one is used as an initial test, and that could be total T4 or TSH, but better is to use a combination of TSH and free T4 as the initial tests, and then add on a T3, preferably free T3, as a third line, as a next test. So she had these results, and what you see here is that the TSH is in the middle of the reference range, free T4 is moderately elevated, and free T3 is also elevated. So you might think this is just hyperthyroidism going on. Next. But with hyperthyroidism, TSH is suppressed because of the high hormones, particularly free T3 and T4, feeding back and suppressing TSH. And a repeat test, which is a good thing to do if the results don't sort of quite fit a typical pattern, is to repeat it and see if this is a persistent finding. And again, the results are pretty much the same with a TSH mid-normal and elevated T4, T3. Next. So the doctor in the clinic involved thought there must be something else going on and asked for a number of other tests. And first of all, looking at pituitary tests, he thought that maybe there's a pituitary disorder rather than a thyroid disorder. And you can see here at first of all, growth hormone and IGF-1, which is a responsive, is a better measure of growth hormone secretion over the 24 hours. Prolactin, LH, FSH, all anterior pituitary hormones are all found to be normal. Then a TRH stimulation test was carried out, which looks at how the pituitary responds to TRH. And the TSH levels went from 2.7 up to 4.1, then down to 3.4 at 0, 60 minutes. Now, a normal response is an increase from the baseline of more than 2 units per liter. So this one is, so it should have gone from 2.7 to 4.7, and it hasn't gone that high. So it's a blunted response to stimulation. Next slide. Other investigations, we're looking at antibodies because often thyroid disorders are immunologically mediated. And antibodies, what are called heterophilic antibodies, can interfere with the measurements of thyroid hormones. So the heterophilic antibodies test was negative, and there were no TSH receptor antibodies. So this is against interference and against antibody-mediated, immune-mediated hyperthyroidism. However, the thyroid peroxidase antibodies were elevated about more than 3 times the upper limit of normal. And that sort of elevation is frequent in thyroid disease, whether it's hyperthyroidism or hypothyroidism. Next slide. Here is just some information about those antibodies. Thyroid peroxidase antibodies are at a high titer in various conditions: Hashimoto's, autoimmune thyroiditis, primary hypothyroidism, and autoimmune hyperthyroidism, less so. So they're not very specific. They're not that helpful, really, because they could also be elevated in people without any thyroid disease. But having such antibodies is said to be predictive of having future thyroid disease. And the advice would be to follow up in the long term. Next slide. Other investigations are measuring sex hormone binding globulin, which you see here was elevated. So why is this relevant? Well, sex hormone binding globulin is synthesized in the liver and is a globulin which transports sex hormones, testosterone, estrogen, and so. And the synthesis of SHBG is dependent on thyroid activity. So an increase in thyroid hormone activity will make liver cells produce more SHBG. So it's showing in this case that the liver cells are responding to increased T3 stimulation, T4, T3 stimulation. Another test carried out, which is only available in one department, as far as I know, in the United Kingdom, and that is Cambridge. And that is the measurement of alpha subunit, which here is, it's not elevated, it's less than 3. And it's a particularly useful test because it will typically be increased if there is a pituitary adenoma secreting hormones such as TSH. The alpha subunit is common to a range of different pituitary hormones, as well as HCG, and is a particularly useful test in picking up active pituitary adenomas. Next slide. Then some genetics was carried out, again in Cambridge, where they have a special interest in these rare disorders, and they could not find any mutations for thyroid hormone resistance syndrome, nor could they find any mutation for familial dysalbuminemia, which can interfere with thyroid function hormone measurements. Familial dysalbuminemia is a condition where a mutation causes an abnormal albumin, which has increased binding of thyroid hormones, and therefore can give you raised levels without there being any increase in free levels. Another investigation was radioisotope scanning, showing an enlarged thyroid and increased uptake. So these findings were consistent with Graves' disease. So far, therefore, we don't have a clear explanation as to what's happening. So next slide. Then there was an imaging study carried out with using magnetic resonance imaging with enhancement. And they found what is described as an asymmetrical pituitary gland. Possibly this could be a micro-adenoma. Next slide. Here is a picture of what was seen on the imaging. And the arrow is pointing to the asymmetry of the pituitary. Next slide. So the question now is considering what these findings mean. There's been a blunted response, as you've seen, to the stimulation test with TRH. And that type of response suggests a pituitary adenoma. In addition, the imaging suggests there might be a microadenoma, or it might be what's called an incidentaloma. Now, an incidentaloma, as is quite common in endocrine practice, is an asymptomatic tumor found by chance during imaging. They can occur in adrenal glands or other endocrine tissues, and they don't produce any excessive hormone. So it could be, rather than a TSH secreting microadenoma, it could be just an incidental finding. Next slide. The other findings, what do they suggest? So the normal alpha subunit, as well as the alpha subunit to TSH ratio, is against there being a TSH secreting pituitary adenoma. The genetic tests, as well as the stimulation tests, are against there being thyroid hormone resistance at the tissue level. However, the raised SHBG by synthesis in the liver indicates that there is a tissue response to T4 and T3. So, and that again is against resistance to thyroid hormones. So moving on, next slide. So first, now we're sort of 3 years down the road from when she first presented. And the results have been pretty much the same over the 3 years. And here we've got some more, again, showing a normal TSH and elevation of free T4 and free T3, which hasn't really changed over the 3 years. Next slide. Now she's again comes along to the clinic, and she's complaining of, as she did in the beginning, of palpitations, and these occur once every couple of weeks, lasting for a few hours. Otherwise, pulse, blood pressure, ECG are normal, but this time the thyroid gland feels a bit bulky on physical examination. Again, some further tests are carried out. Free T4 is probably higher than before, but otherwise same pattern. And cortisol is quite low. So it might make you wonder, could there be a deficiency of ACTH, or could there be autoimmune adrenal disease, or is there something else affecting cortisol production? But that single cortisol, a random cortisol, is not really very helpful in a diagnostic sense. So you would need to do dynamic function testing, particularly synapse stimulation tests, to further investigate the cortisol side of this problem. Next slide. Again, more tests are done, and all of these are normal, including the bone profile, estradiol. No change, really. Next slide. So she now has another pituitary imaging study done. And again, the same sort of finding, persistent asymmetry of the pituitary with, it's reported, a possible small micro-adenoma in the right anterior pituitary. Same as before. Next slide. It's reported there's been no significant change in the size of the pituitary since the previous examination, and the adenoma or incidentaloma still measures the same 6 millimeters in diameter. Otherwise, the pituitary looks okay. There's nothing else to see. Next slide. Okay, so another set of results: higher free T4, high free T3, normal TSH. Again, next. More investigations a year later, same again. Other tests, oops, no, go back. Other tests, vitamin D, other tests are normal. They didn't really pursue the low cortisol finding, which perhaps we've missed something there, or perhaps it was done, but we didn't pick it up in the review of the case notes. And there's been no change in weight over the 4 years. Next slide. So we're now, therefore, in a position to think about what is going on and what, if anything, needs to be done. The picture could be described as being euthyroid hyperthyroxinemia, although there are palpitations, but otherwise there is nothing very much in the way of clinical findings. And one possible explanation is that this is part of the syndrome known as thyroid hormone resistance, which in this case may be due to an unidentified mutation, because the gene that codes for the thyroid hormone receptor has been shown that there are maybe at least 100 mutations affecting that gene. And they've only looked for a few of these mutations, and there may be other mutations which have not been picked up. This particular resistance syndrome was first described by a man called Refetoff in 1967. And it's now recognized that the incidence of this is about 1 case out of every 50,000 live births. So fairly rare, but not extremely rare. On the other hand, it could also be a pituitary secreting TSH-oma, but there's some of the results are in favor of that, some are against that. And the prevalence of this rare condition is something like 1 or 2 cases per million of the population, so much rarer than resistance. However, an incidentaloma is not that unusual. I mean, they've done in autopsy studies and found that the prevalence of pituitary incidentalomas is about 10%. And on using MRI studies, they found pituitary adenomas may occur in as much as 1/3 of the imaging studies carried out. So it's quite a strong possibility that we're dealing with an incidentaloma with possibly thyroid hormone resistance due to an unidentified mutation. Next slide. So if you look into the literature on Refetoff syndrome or resistance to thyroid hormones, there are two types, alpha and beta. There are two types of receptors, and the gene can code for either of those. It's thought that this patient might have the mutation of the beta receptor. And in that case, there would be a blockage, there would be no negative feedback or reduced negative feedback on the hypothalamus and the pituitary. So if there is an increase in T4 and T3, as we showed here, it doesn't feed back to suppress the hypothalamic pituitary axis. And there is variation in how peripheral tissues might respond because the expression of the thyroid hormone receptor is variable between different tissues. So you might have a normal response in some tissues, as it says here in the liver. So that would explain the high SHBG. And there could be a hyperthyroid-like response in other tissues, such as the heart giving palpitations. So I think that this case would best fit in with what you might call a beta receptor resistance. The other type is the alpha receptor resistance, which has different features in that it gives more hypothyroid-like symptoms as a result of blockage of tissue action. But there is still negative feedback occurring to the hypothalamic pituitary axis. Next slide. So what next? So faced with this patient, the question then arises, what, if anything, should be done? So one possibility that has been considered is that you can use a drug called octreotide, which is a somatostatin-like substance, medication, and it reduces the secretion of thyroid hormones. And it's also useful for reducing secretion of pituitary hormones or from any adenoma. And that this might be of value in the longer term to reduce the risk of developing osteoporosis or atrial fibrillation as a result of the higher T4 and T3. Another therapeutic option is to use a beta blocker to deal with the palpitations. And because of the increased risk of bone osteoporosis, it might be a good idea to check bone density every few years, but not necessarily have any medication being used. So those are the sort of situations that it's not a definite diagnosis here. It's on balance, I think, probably resistance to thyroid hormone. But the question is, what should you do about it? That's not clear. Next slide. So I think perhaps to finish on this case, which we've gone quite quickly really, it's the learning points, I think, are this syndrome, resistance to thyroid hormones, is a rare autosomal syndrome with impaired responsiveness to thyroid hormones, impaired responsiveness to T4 and T3. The diagnosis is based on the clinical findings of discrepancy in thyroid function testing, and usually you would need a genetic test to confirm what's going on. And it's quite important to consider this condition if you have a patient with a goiter, elevated T4 or T3, and non-suppressed TSH levels, because it would be wrong to start unnecessary treatments. It could easily happen that you would start using anti-thyroid drugs in this setting, whereas really it's not appropriate to do so. Now, having worked in Liverpool and the United Kingdom for all of my professional life, I don't really have much of an idea of how things are different in other parts of the world. So I thought I'd better find out if there's anything different in Africa about thyroid disease. And it seems to be quite easy to find out, because if you do a search, artificial intelligence soon comes up with a list of references about thyroid studies carried out in Africa. So I've summarized here what I think perhaps is being described about thyroid disease in Africa, and that it's, to my surprise, it's mostly due to iodine deficiency. By far the most common form of thyroid disease is related to deficiency of iodine. And this condition might lead to goiter, might lead to hypothyroidism, and might lead to hyperthyroidism. I've also found out that autoimmune thyroid disease, which is probably the commonest cause in Europe, has quite a high prevalence in Africa, varying in studies from between 1 up to 10%. I found something about the prevalence of thyrotoxicosis in Nigeria, where it's just over 1% of the population. And it's usually autoimmune hypothyroidism, but may also be due to other conditions such as inflammation, thyroiditis, which is called thyroiditis, or medications may have an effect and cause thyrotoxicosis. Then endemic goiter is particularly very prevalent in iron deficiency areas in Central Africa. And even if you take one country, you will find big variations between regions in the same country in the percentage prevalence of iodine deficiency. The goiter prevalence in Africa as a whole is in the order of 1/4 of the population, which I find is perhaps hard to believe that. But hypothyroidism is only 5%. Perhaps the learning point is there that there's there are many goiters around due to iodine deficiency, but only a small proportion of them will lead to hypothyroidism, and another small proportion will cause hyperthyroidism. And in particular, it's been noted that iodine can induce thyrotoxicosis, because in an individual with chronic iodine deficiency, if there's a sudden increase in iodine intake, this can lead to a surge in release of thyroid hormones. So here, these are just a few of the things that I've discovered by having a look at how thyroid disease might be different in Africa. And it seems to be mainly a lot more, a problem with iodine deficiency, goiters, and the consequences of goiters. But at the same time, there are autoimmune conditions causing hypo and hyperthyroidism. So that's just a bit of information on the epidemiology of thyroid disorders. Next slide. So I thought it might be particularly helpful to look at thyroid function test interpretation, because as a professional working in a laboratory, you are very likely to be involved in the interpretation of results, perhaps on a regular basis every day when results go out after the reports are produced, or if you're asked in a consultation by somebody to give your advice on the interpretation of results. And in general, I find that hospital specialists, of course, especially endocrinologists, often can make sense of the results without needing to ask questions. But they will come and ask you if they can't make sense of the results that have been produced. Whereas in general, family doctors working out in the community would prefer to have comments with as much as possible with results. Even just to say it's normal or whatever you can add seems to be particularly appreciated. So if we go to the next slide, I've just put down here the sort of interpretations that can be used for adding to thyroid function test profiles. So if you have a combination, the first one here, of elevated T3 or T4 with suppressed TSH, you could say that that is probably primary hypothyroidism. And you might therefore add a comment to those results on the report saying results consistent with primary hypothyroidism. It doesn't necessarily, it may be not such a good idea to just say it's primary hypothyroidism, because there could be other things going on that you're not aware of, but you could nevertheless say that it's consistent with that diagnosis. And then if we look at the next one, T3 toxicosis is another variant of hypothyroidism where the free T4 is normal, but just the T3 is elevated with a low suppressed TSH. Then it's worth probably adding there. These results are consistent with T3 toxicosis, which is just a variant of the typical hypothyroidism. Another type of hyperthyroidism is known as subclinical hypothyroidism, where you have normal T4, T3, but a suppressed TSH, which may go on to lead to overt hypothyroidism. So a comment in that setting might be that these results suggest subclinical hypothyroidism, and so on. So there are a list here I've just put together on typical patterns and the sort of comments that you might add to the results. You probably wouldn't want to look at all the results that are coming out every day, because there'd be just too many coming through and you've got other things to do. But you could have a system, as we had, whereby you look at only those results that are most abnormal, or you can decide on which cutoffs you're going to look at. So you could say, I won't look at any results that are completely normal or within the reference range. I'll just let them go straight out without anything further. But anything with an abnormal TSH or an abnormal T4, T3, you could consider looking at that and adding a comment. I think that in that way, you enhance the value of the report and you give further information to help with interpretation and further investigations. So some examples of the sort of comments that might be added are saying the results are consistent with the euthyroid state. You might want to do that, or might think you don't need to do that. You could say a suppressed TSH is consistent with excessive thyroid hormone replacement if you know the patient is taking thyroxine replacement treatment and you have a suppressed TSH. So that's just a few examples of how comments can be useful to the clinician if it's added on by a laboratory professional. So I thought we would run through a series of examples of results, scenarios that you might come across when you're reporting results, or that you might be faced with if somebody phones in to ask for your opinion. So if we go to the next slide. So just imagine yourself sitting here, you're working at your desk, you come across these results. How do you respond? You've got the information you've got on your system is that it's a 30-year-old woman. She's been losing weight and she's complaining of, or she's sweating and a tremor. So you haven't got a full picture, but you've got some of the basic clinical details. And then you've got results here, which in this case, it's a suppressed TSH, clearly, with a normal free T4, increased free T3. So I could just perhaps ask if anybody would like to suggest what comment might you add to this report? I don't know, can we do an interactive response or?
Yes, please, you can unmute and share your thoughts. Anyone? Yes, Sharifa, please unmute. Go ahead.
Okay. Can you hear me?
Yes, I can hear. Yes, thank you.
Okay, I think based on the clinical presentation and the picture I'm seeing in the result, even though the free T4 is within the reference limit, I will still report in favor of primary hyperthyroidism because the free T3 is elevated and the TSH is markedly suppressed. Or I can also give another suggestion of free T3 toxicosis as well. Thank you.
Yes, excellent. That is I think the best thing you can add to that is to say that these findings, considering the history you've got, are consistent with primary, probably autoimmune hyperthyroidism, or can be described as being T3 toxicosis. So I think we would probably, when I was practicing, we would just add a comment saying results suggest T3 toxicosis would be one way of putting it. And what you said is very good. That's right. I agree. So okay, let's look at this one then. So here again, another 65-year-old woman on thyroxine, 150 micrograms a day, feeling well. And you've got here again a set of results. And again, I'd like to invite anybody to make a comment. What would you add a comment? And if so, what wording would you choose to use?
Please unmute and share your thoughts.
I welcome you're very welcome to make any comment because it all helps towards the discussion, and it doesn't matter if you're wrong or right. But there's sometimes there is no right answer, but there's a
yes.
Like to hear.
You can share your thoughts.
Yeah, this is Dr. Uya. Thank you for the presentation. With this clinical picture of a 65-year-old woman on 150 milligrams of levothyroxine, and the biochemical picture of a low TSH level with the slightly elevated free T4 and normal free T3 levels, it's suggestive of an excessive thyroid hormone replacement.
Right. So what comment would you add to this report then?
I would say that this report may be suggestive of an excessive thyroid hormone replacement and a review of the patient's dosage of medications of levothyroxine will be appropriate.
Yes, and would there be any concerns about not changing anything, just leaving it and accepting it as satisfactory?
Yeah, it will be important to simply to review because the free T4 levels are elevated, then it would be important to increase the dosage.
Yeah. Well, I suppose the concern might be that if you're giving too much thyroxine, then there's an increased risk of, in the long term, of having atrial fibrillation or bone disease. My colleagues working in endocrinology did discuss this these set of results, and their opinion was that often to deal with the symptoms of a patient, you have to give them a higher dose of T4 thyroxine, achieving perhaps a slightly increased free T4 level and a slightly suppressed TSH. Their opinion was that probably you might want to continue using this dose. And having a free T3 in the normal range suggests that it's at the tissue level, perhaps not causing overactivity. But if you look at the literature, then mostly it will say that the target for using T4 treatment should be achieving a TSH level within the reference range. And you should not continue with suppression of TSH. So there are different opinions on this, but I think in general, most people probably would say that the TSH target on replacement therapy should be within the reference range. And the comment I think you could add to this one is that these results suggest over replacement with T4 suggest reduced dosage, which is pretty much what you said, yeah. But there is some controversy about whether this is perhaps desirable, having results like this, because you're relieving the symptoms.
Thank you.
Okay, next one then. Okay, now here we go. A 35-year-old woman. She's considered to be thyrotoxic, or she's known to be thyrotoxic, and she's been treated with an antithyroid drug, carbimazole, for the last 4 weeks, only 4 weeks. And I've just shown you a picture there of a very obvious thyrotoxicosis and improvement on treatment, but you might not get that sort of improvement in just 4 weeks. But anyway, the results are here, and as you see here, we've got low TSH, low T4, low T3. So again, I invite you to suggest whether you would add a comment to this one, and if so, which comment do you think is most appropriate? Anyone?
Please unmute and share your thoughts. Yes, we have Chioma Ude. Please go ahead, Chioma.
Good afternoon, sir. My comment would be that the reduced free T4 is consistent with excessive antithyroid treatment. The suppressed TSH may take many months to normalize following commencement of antithyroid treatment.
Chioma, can you please repeat? Yes, please just repeat your answer.
Yes, hello, please. Yes, I'm not sure I could hear you properly. Could you just repeat your answer?
Chioma, you have muted. Please unmute. Well, Chioma seems to have muted, but let me check this. There's something on.
Right.
Okay, yeah. Yep. Chioma, please, you could put your answer in the Q&A box. Then I can read it out.
Okay, well, perhaps I can comment on what we've got here, in that presumably this patient, and you could look back and see that the results previously were probably typical of thyrotoxicosis with a suppressed TSH and high free T4 and or T3. So it looks as if the carbimazole is working very well by reducing the T4 and T3. But it may be that it will take longer, it often does take longer for TSH to readjust to another level. And if it's been suppressed for a long time, well, for months or a year or so or longer, then it will take time for the pituitary cells to recover and start producing TSH. So you might add a comment here saying that the patient, these results suggest the patient is responding to treatment with carbimazole because of the T4, T3 being down. You could add a comment to say that it might take longer for the TSH to recover to a normal value. But the comment you would add would probably depend on whose care the patient is under. Because if the patient was under an endocrine specialist, you probably wouldn't really need to add any comments because they are experienced in dealing with this sort of treatment and they would know how they carry on. Whereas if it was the patient was being managed by somebody perhaps with less experience, then you might add the comment saying this patient is, or the results suggest good response to treatment. So it's not that straightforward, this one, but I think it's perhaps the point here is that TSH will take time to readjust if you once you start treating. Okay. Shall we go to the next one then? Okay, here's another common scenario. A 38-year-old man feeling tired, putting on weight, and he's been found to have a goiter. So you've got here those just TSH, T4, and antibodies. Anybody would like to come up with how you would interpret this?
I think my comment is going to be, I think, is primary hypothyroidism or subclinical. But I will want to go with primary hypothyroidism because of the level of elevation of the TSH. Usually when TSH is above 10 milli international unit per liter, I think it's quite enough to interpret it as an overt hypothyroidism. Coupled with the presence of the TPO antibodies, I think I will further describe it as it's likely to be an autoimmune hypothyroidism. Thank you.
Yes, I think you're correct there. In particular, noting that the TSH elevation is not mild, but it's more than double the upper limit. I guess the free T4 here is at the lower end of the reference range. And therefore, you could say that this is what's called as compensated hypothyroidism. You may not necessarily say it's subclinical because there's tiredness, but that's rather a non-specific symptom. So you might say subclinical, but compensated hypothyroidism is probably a better comment here. And in this setting, it's recommended by specialists that you should start on thyroxine replacement treatment. Once you get a combination of TSH as high as this, together with antibodies, then irrespective of the free T4, whether it's low or has been compensated, that in itself is a good enough reason to start replacement therapy. So I think you could say that this is probably primary autoimmune hypothyroidism. And although it's compensated, these results would suggest you should start on replacement therapy. So from a practical sense, you may not want to have a long discussion on the report, but you might say results consistent with compensated hypothyroidism. You might, depending on who's requesting, you might add on another bit saying suggest start thyroxine replacement treatment. Good, next one. A 30-year-old woman attending for a health screen, feeling good, no health problems, and results show very suppressed TSH, but normal T4, T3. At that stage, nothing is done. 3 years later, she has developed symptoms, tremor and breathlessness. And again, same tests are done. And here are some of the results. So you can see a change in free T4. So this one should be straightforward. What comment would you add to these results? Or would you want to add a T3 test?
Thank you. So the first result is showing a subclinical hyperthyroidism. And 3 years later, we are looking at results showing a low TSH and a significantly elevated free T3, which is primary hyperthyroidism. Given the age of this patient, it's likely we could be dealing with an autoimmune hyperthyroidism, possibly Graves' disease. So my comment would be to screen for or follow up with the test for the antibodies, specifically the TSH receptor antibodies, and then commence anti-thyroid medication.
Yes, you got here your free T4 is very high. Would you add a free T3 or would you leave it like this?
Well, I would leave it like this. Traditionally, the entire panel, the TSH, 3T, and T4 are measured, but the low TSH and elevated free T3 confirm the diagnosis of primary hyperthyroidism. I don't think adding the free T3 test would change that significantly. So I would be okay with this.
Yeah, okay, well, I very much agree with that. So yes, you don't need a T3 in this setting. T3 is often a better test for picking up thyrotoxicosis than T4, but in this particular case, you've got a very clear picture here with T4 being markedly elevated together with continuing suppression of TSH, as well as typical symptoms of thyrotoxicosis, the tremor and the breath, well, tremor particularly. And this is also the age group. A young female may well have this sort of combination of findings. So I think you can conclude without any doubt that this is primary hyperthyroidism, also known as Graves' disease, but perhaps just the hyperthyroidism is a better term. I mean, there is debate about whether you should be using wording such as Graves' disease or Hashimoto's disease or these various eponyms. They say just the purely medical scientific terms are probably better than names of individuals who first described it, but nevertheless, these terms are still used quite a bit. Like Graves' disease, I think, is very commonly used. So yes, your comment is I think is good. I would say results consistent with primary hyperthyroidism. And I would suggest adding that antibodies, a TSH receptor antibody, and starting on anti-thyroid medication. Okay, very good. Next slide. Right, so here we are. Dry skin in a somewhat older female, and those results. And here we go. Anybody like to comment on this? Well, you might say too easy, this one. So,
yeah, Sharifa, please go ahead.
The finding is consistent or is in keeping with primary hypothyroidism.
That's right. Yes, I mean it's very clear cut here. There's no doubt. And you certainly wouldn't do a T3 measurement, but you wouldn't do that anyway if there's a query about hypothyroidism. T3 is not a good test for diagnosis of reduced thyroid function, whereas T4 together with TSH is the right combination to use for that setting. There have been studies published of looking at the value of T3 in hypothyroidism, and the conclusion has been that it's not useful because it may be suppressed or normal, and it's not as good as the other tests. Okay, so this is very straightforward. Primary hypothyroidism, likely to be autoimmune. You probably don't need to do antibodies, but I think you have enough here to treat. So moving on, next slide. Now, this one is perhaps a little bit more difficult. An elderly woman who's in a nursing home, a care home, and the clinical details you're given is she is hypothyroid, known to be hypothyroid, and the reason for the test is to see whether she's having adequate replacement. It's not a question of hypothyroidism, it's a question of replacement treatment, about replacement treatment. So you've got these results, and if you compare them to previous results, they've been pretty much the same for a number of months. So would somebody like to comment on this, please?
Okay, from the picture, I think I will say that replacement is adequate because the free T4 value is becoming into the normal range. Even though the TSH is still elevated, it might be that it will take some time because of some pituitary lag for the TSH to fall into the reference range. Maybe she has prolonged hypothyroidism that is now on treatment. And I think there is a response here, according to what I think.
Yes,
Thank you.
That's good. You see, however, the previous results, going back as much as 6 months ago, were giving you the same levels, the same TSH. So you might say that should be enough time for the TSH to adjust.
So Blessing has commented in the chat.
Okay.
And her comment is that a replacement is inadequate. She's not giving the reasons why she thinks it's inadequate, but that's her answer, that a replacement is inadequate.
Right, yes. So I think that's another consideration, is that because the TSH is not coming down, and it's been like that for a number of months, 6 months, that you might say this woman is not having enough replacement. Another factor that's important here is that she's very old, 92 years old, and she's in a care home or nursing home, care home, it says, and therefore she may not necessarily be taking tablets every day. This is could well be a problem with what's called compliance or adherence to treatment, and that with older people, this is quite a common problem, that they should be taking a certain dose every day, but some days they forget, or the staff or whoever's looking after them forgets, and therefore they may be, when they do take the thyroxine, they're taking enough, but because it's not consistent, that the TSH will be going up and down, or in this case, staying too high. So I would have thought, if I were to put a comment on this one, I would probably query the compliance with treatment. Something like wording like, consider poor compliance or reduced compliance with medication. Because the free T4 does suggest that when she's taking it, which may have been just a few days before the sample was taken, she's taking enough. But if she hadn't been taking it for, say, several days earlier, before that, then that could be the reason why the TSH has gone. It's still as high as it is. So I think it's more, this would go with reduced compliance.
Yeah. So Charles, there are a number of chats in the Q&A. So Geoffrey talks about needs to think about compliance.
Yeah.
Blessing talks about TSH guides treatment.
Yeah.
And Chioma says replacement may be considered as inadequate. Compliance might be a problem here.
Yeah. So it's probably true to say it's inadequate because she's not taking the right dose every day. But it could be that the dose is right, but if she took it every day, then it would be okay. But you don't know all that. So it's just, this is more likely to be a problem in elderly people who are not fully taking what they should be taking. So good, yes, you could say it's inadequate. You might, on the basis of the TSH, you could say this is inadequate replacement. Okay. Next one. Okay, here we go. So this is quite interesting. It's an older female taking thyroxine. And results are not only thyroid tests, but also there's a calcium and a phosphate, as well as thyroid function tests. So, and then when you look at these results, you then look back and find that 3 weeks ago, there was another calcium test was done, and it was pretty much the same sort of level, a bit higher 3 weeks ago. So faced with these results, what comment might you add? Anybody like to suggest a form of wording which would be suitable, appropriate for this report?
Okay. I can see like 2 different pictures here. Because of the hypercalcemia she has, with an adjusted, have very high calcium, adjusted calcium, and hypophosphatemia. So I'm thinking about PTH. Is it that maybe she has hyperparathyroidism as well as primary hyperthyroidism at the same time?
As well as primary hypothyroidism.
Primary hyperthyroidism and also hyperparathyroidism. That's what is giving the high calcium with hypophosphatemia.
Yes. Well, she is on thyroxine, so
okay.
You might therefore think that she was diagnosed as having hypothyroidism to start with.
Yes, I forgot. I didn't see the drug she was on. Okay,
yeah.
being on T4 as a form of treatment, then she may likely be hypothyroid initially and was placed on the thyroxine. Then this shows that there may be over-treatment with T4.
That's right, yes. It could.
And then tilting her to hypothyroidism because of the over-treatment.
Right, so yes, so it's right. That suppressed TSH with a high free T4 would fit with this being too much thyroxine, over replacement. And too much thyroid hormone might increase the calcium. That can lead to hypercalcemia. One cause of hypercalcemia is thyrotoxicosis. So excessive thyroid hormones can lead to hypercalcemia. But that would usually go together with a raised calcium and a raised phosphate.
Yes.
Whereas in this case, as you've identified, the phosphate is reduced. And whenever you see this combination of a raised calcium, which is persistent, together with a low phosphate, it raises the possibility of primary hyperparathyroidism. And therefore, what you should do in this setting is repeat the test together with a parathyroid hormone measurement. So I think a good comment for these results would be that the thyroid results are consistent with over replacement, and there's a need to reduce the dose of thyroxine, and the raised calcium and low phosphate suggest primary hyperparathyroidism, and you would suggest repeat with a PTH measurement, parathyroid hormone measurement. So how's that? That's what I think. Okay, move on. Last one. Time's up anyway. So this is one I found in the literature. This is somebody with endemic goiter and dry skin. so in a young boy, and you've got these results of TSH, free T4, T3, and any comment you would put with this one? I mean, you wouldn't necessarily get a photograph, of course, with the request, but here is the example of this particular case.
So I think this is a case of primary hypothyroidism, which is likely due to some iodine deficiency, since it's because of the goiter, possible iodine deficiency.
Yeah, I think that's right. This is it is an endemic goiter due to iodine deficiency. We don't necessarily know whether that is there, but that's quite likely. And the T4 and TSH tell you that it's hypothyroidism. The free T3 being at the upper end of the reference range doesn't really take away anything from that, because T3 can fluctuate quite a bit in hypothyroidism, and it may be a response to low T4 that more is being converted peripherally to T3, but it's not a useful discriminatory test in the setting of hypothyroidism. So I think this is all the comment you could put here would be consistent with hypothyroidism, possibly iodine deficient goiter. So I think there we are. We've finished.
One comment.
Any comments? Yeah.
One comment from Sandra. So Sandra says it is primary hypothyroidism with preferential formation of T3.
Yeah. That's good. Yeah. But you would need to do something. Probably here the treatment would be iodine replacement, and probably thyroxine replacement as well. Okay, so I think that's it. That's my last slide.